get started. You are very lucky because Lights and Sound took up my 15 minutes this morning and cut that out, so I will not be speaking for those 15 minutes. But I'm Deb Silverstein, I'm the state director, and I want to welcome everyone to our 10th annual state conference. I especially want to welcome those that are here for the first time. How many first-time attendees do we have? A very, very, very warm welcome to you. We hope that it's not the first time that you come, or the last time that you come. We hope that we have a nice long relationship with SPAN Ohio and moving forward to obtain our goal of true health care justice for everyone. Okay. Today we have two very, very good speakers, and I want to start by introducing the first one. Our first speaker is Lori Wen. Lori joined the health justice movement through the AIDS activist group ACT UP and currently serves as the executive director of Physicians for a National Health Program, New York Metro. She's a steering committee member of Healthcare Now, where she was a staff organizer in 2009, and that's where I first met Lori. Lori is very dynamic, and she has wowed me every time that she has spoken, and I'm sure she's going to do the same to you. And with no further ado, Lori Wen.
So, here's why I think it's crucial that we need to work on state single-payer campaigns as the Affordable Care Act moves forward. So a few months ago, I went to see my doctor, a new doctor. And she recommended a medication and pointed to a brochure. Here, take a look. And then she made some comments about the pharmaceutical company that made it and how much it bothered her that they were pushing the way they were selling and pushing and marketing that drug. And then she made some further comments about the nefarious effects of corporate interests on healthcare. And I just had this big grin on my face, and I said, wait till you find out what I do for a living. She said, what do you do for a living? I work with an organization called Physicians for a National Health Program. And she said, I love you. She really did, really. That's not the reason we need to work on state single-payer campaigns. That's coming. Okay. So then she said, I love you. I also have to confess. I was a member about 15 years ago. I'm sorry I haven't paid membership dues in a long time. I still really believe in it, and I think it's great that you're working on it, but I lost hope. I just didn't see, I didn't see how this could possibly happen, especially with the passage of the Affordable Care Act. You know, it's a great ideal, but sorry, I just don't see how it's gonna happen. So I said, well, I understand your frustration, but did you know about the New York State single-payer bill? She said, no, tell me about it. So the whole conversation changed and the whole energy of the room changed. And that, to me, in a nutshell, is why we need to work on state single-payer campaigns. On the most basic level, you get your foot in the door to even have that conversation. So a big part of organizing, of course, is to give a sense of the possible, to give a sense of hope. And I think that's exactly, from that conversation with my new doctor, that's exactly what happened. She had been discouraged and basically left the organization for 15 years. And even just bringing up the state single-payer bill, and I told her a little bit more about it, about how much progress we made, how concrete the progress was. It changed her whole view of what was possible. Now, of course, giving a sense of the possible is not the only thing that's gonna, actually get us to single payer. We do have an $800 billion industry against what we want. So I'm not naive that just because we all feel hopeful, it's gonna just happen. But without it, it's never gonna happen. So I'll come back to this part again about how state single payer campaigns can provide a crucial organizing platform. But let's kind of zoom back out from this little story to look at history, to look at why this is important, why it gives people a sense of hope. So when you look at American history, there are many, many, many examples of fundamental social change that came first on the state level and then national. Women's suffrage, of course, is one of the most obvious examples. It wasn't until 1920 that nationally women had the right to vote, but for decades, activists working on a state level, not that they were giving up the national fight, but it's exactly because they work hand in hand. Everything that you do in terms of education and movement building on the state level strengthens the national movement, right? So for decades, different states, different activists in different states were seceding and pushing the envelope nationally, and then eventually in 1920, that became law of the land. Of course, right now, the really obvious example to bring up is marriage equality. I mean, who would have thought 5 years ago? Would you have thought that at this point we would have 9 or 10 states in this country that have legalized gay marriage? It really is. And I come out of the ACT UP movement, LGBT rights, of course, very central to the AIDS movement, and I think everybody is very happily shocked in terms of where we are. Maybe everybody except for the people who were at the front line of that movement, because they knew what they were doing. They've been doing a fantastic job. So it's been very inspiring, I think, to single-payer activists and to activists working on a lot of issues, looking at how the marriage equality movement has gained momentum and very concrete legislative victories in so many different states, and how that translates into moving the national fight forward. And then, of course, when you look at Canada, a single-payer country, probably many of you in the room know that Tommy Douglas was the Premier of Saskatchewan. He was the architect of Medicare. He started in Saskatchewan, and because it did work so well, despite initial strikes by physicians and a lot of opposition, it, of course, was a brilliant idea, saves lives, saves money, and it did eventually expand to the whole country. And probably many of you know that he was voted the greatest Canadian of all time by 1 million individual Canadians. I actually often bring that up in legislative meetings. When people, how many of you have been in legislative meetings where your legislator says, well, yes, of course I believe in this. Yes, I agree with your ideals, but you know what? I can't stick my neck out. I cannot stick my neck out on this issue, because if I lose this position, this is not helping you or other groups that have similar values. So I just can't stick my neck out. Well, look what happened to the guy who stuck his neck out. He became the greatest Canadian of all time. So appeal to their sense of political legacy and greatness. So why do state campaigns work? Why is it that, of the examples that we just mentioned, why are they able to lead the way? And I guess the reasons are pretty obvious, but I'll go through them anyway. One is, of course, psychological. The second one is more about data, which I think is much less of an issue with marriage equality or women's right to vote. With health policy and healthcare systems, there is a sense among many sensible people that, well, we don't really know what this is, and if there's some data, then we'll feel more comfortable. Now, that is a misconception. We have tons of data. We have Medicare, we have the VA, and we have a few dozen countries in the world. There's decades and reams of data. But nevertheless, it doesn't help us just be dismissive of that desire that people have if they want more data. That's part of what is very attractive about having one state, two states go forward and amassing data and being really a demonstration project that would help people who are skeptical but who are sensible and would actually respond to data. Obviously, many people are not in that category. That would help that category of folks. The second one, I think, is much more important. It's about psychology. And it's about reducing the fear factor, the fear of the perceived unknown crazy idea, which again is a misconception. But that fear is substantial. And having it happen in one state first, another state, that does help quiet down the fears of a lot of people. And then a sense of solidarity among states working on state campaigns. And again, I do not mean to create a division between groups and states working on state campaigns and national. I think the whole point of what I'm saying is that state campaigns strengthen the national fight. Together, we work on this collectively. And this reminds me of a conversation I had with James Haslam, who is the director of the Vermont Worker Center. And again, I'm sure many of you have heard about the Vermont Worker Center. They took a leadership role along with Dr. Deb Richter, former president of PNHP, and other groups in Vermont that resulted in the really impressive success a couple years ago, the passage of a bill that leads to single payer. It's not single payer quite yet. Right? Passed a bill. It's a 3-part bill that leads to single payer, but it's by far the most progress we have had in this country on this issue. So I asked James, what can we as New Yorkers do? What is the single most effective thing that we can do to help you in Vermont? Because number one, we want Vermonters to have the system. Number two, we understand the implication this has on the rest of the country. So I realize how important it is that we support your fight. Tell me how. And I was a bit surprised by his answer. What do you think he said?
Do your work in New York.
Okay, yes, that's it. That's exactly it. The best way you can help us is to fight in New York. You're going to prove to the country that Vermont is not an outlier. You are absolutely going to strengthen what we're doing in Vermont by strengthening your own state campaign. So that's a very important lesson. So now we're going to go back to how much and how effective a kind of organizing platform state campaigns provide, kind of back to the story of my doctor, of giving that sense of the possible, of renewing the interest and the commitment because people, often for the first time, feel like it's possible. And I'm going to talk about 3 categories of people for whom I think this is a very, very effective organizing platform. I'm going to talk about targets, allies, and constituents. Targets, obviously, are the people with the power to satisfy our demands, and in this case, state legislators. I don't know as much about Ohio, whether the following is true. In New York, there are the 3 most common paths. Well, 2 of these paths I know is true. The third one, we'll see. There are 3 most common paths for state legislators to take after they leave the state legislature. What are those 3? Okay, lobbying, 1. Congress, 2. And 3, this is the one that I'm not sure if it's also true for Ohio. Yes, prison, unfortunately. We actually just lost we lost a couple co-sponsors lately to either actual prison sentence or impending trial that may result in it. So it's very unfortunate, but it's true. Right? Okay. So those are the 3 most common paths. And the one that is important to this discussion, of course, is Congress or Washington, D.C., because it actually includes the White House. Obama, of course, is the most famous former legislator, right, a state legislator right now. Right. So 50% of current congressional representatives, senators in D.C. are former state legislators. That, to me, is a very important number. When they're in your state legislature, they are, of course, much more accessible. They are less powerful, and therefore they are more accessible. You can much more easily contact them, call them, go to their offices, and have meetings with them. And because their districts are smaller, you can also much more easily show them a petition supporting your cause that has more names than the margin with which they won their election. Right? I think that's important. What is it that ultimately they're in there for? Right? Sometimes we feel like some of them They're in it for the money and the power. But obviously, if they lose their seat, that's it. They won't have it. So if you can show them a petition supporting your state single-payer bill with more names than the margin with which they just won their seat or won the seat a long time ago, that is a powerful thing. And also because they're earlier in they tend to be earlier in their careers, although sometimes people are there for many decades. They are also more likely to be open, to be solicited, to become a champion of a particular issue than later on in their career when they've kind of set in their ways in some ways. One example in New York, one of the state legislators, his name is Hakeem Jeffries, and I didn't know about him. We have 150 state assembly members in New York State. I don't know about all of them. I've learned quite a bit about some of them. And I remember asking our champion, the author and sponsor of the bill, Assemblyman Godfrey, who's also the Health Committee chair. That certainly helps a lot. I asked him, can you name 2 other potential champions? We want to help groom at least 2 of your colleagues to help you, lead this fight, because we are so thankful that we have you, but let's try to groom a few more. So I asked him for recommendations and candidates. One of them was Hakeem Jeffries. So I started looking him up. I tried to get a meeting with him when we had one of our lobby days. We weren't able to, and I figured it was logistical. I didn't think it was anything really intentional. But I was then in the State House lobby, and I saw about 30 girls, 14, 15-year-old girls, standing there listening to somebody talk. And I looked over, and it looked like Hakeem Jeffries. And I remember I wasn't able to get a meeting with him. That looks like Hakeem Jeffries. So I talked to one of the girls, and I said, is that Hakeem Jeffries? She's like, no. And her teacher looked at me and said, yes. So they had no idea who they were listening to, but I was very focused. I knew who that was. So I waited till he was done talking, and I introduced myself. I walked up to him, and I said, may I just accompany you back to your office? It's a 5-minute walk. You can do a lot in 5 minutes, right? I mean, remember the how much money people pay for just a 30-second advertising spot, right? So that's 10 of those. So you can do a lot in 5 minutes. So just by getting his permission to walk with him from the lobby to his office, I did my pitch, I had materials ready, and he was receptive. So I felt pretty good about that 5-minute thing, but I thought it was still gonna take maybe a bunch of follow-up. But after that, about 10 days later, I hadn't even had time to follow up yet. I got busy with other stuff. He signed on, actually without further prompting, which was a bit surprising. And then I had a follow-up meeting in district, and I was able to get, I think, 7 of my members, 7 physicians, most of whom, they either lived in his district or they worked in a hospital in his district. And I previously, I think, knew one of them. The other ones I did not know. I have a current and former membership database of about 3,000. So I started this job 2.5 years ago. I obviously don't know every single one of the 3,000 former and current members. So I sort their districts. I call them up cold because most of them I had not met yet. And to my surprise, everyone I contacted but one was able to come. They rearranged work, they rearranged other things to come. That is a very important lesson. It was something very local, very concrete, and they saw that it was possible for them to do something and to succeed at it. That's a very important thing for people to continue to want to do something, right? So we had that meeting, and because he was already on the bill, it was, of course, about strategizing about how to actually gain support in parts of the state that did not have as much of it. This whole story about Hakeem Jeffries has to do with where he is now. He is now in Congress. And I have met with him since he, just in the last few months, since he became one of our newest congressperson. And it's a kind of relationship that we've been building, and it was much easier for me to get through to him and to get him signed into the bill and to get our members to meet him when he was in the state legislature. So we'll see what's going to happen. Again, just because one is educated about it and even publicly supported and sponsored a bill while one was in state legislature does not automatically translate, of course, into being a champion for it or even active support of it when they get to Congress. Of course, we know that President Obama, that very famous video from 2003, we know that he understood it and supported it. So political realities are something that we are aware of. Nevertheless, this path, get to them when they're more accessible, I think is a very useful thing to remember. So Hakeem Jeffries, I had never met him, but doing some research, I seen his photos, so it was it's important to recognize what your state legislators look like. Another single payer activist in New York, Omar Cuddy, who is fantastic, he makes jokes about how every night I study pictures of the legislators so that if I run into them, I can harass them about this bill. I sometimes run into them in, just in the city, in the subway, and I do. That is not true. I do not do that every night. Just Saturday nights, which tonight is legislative photo studying night. So the second category of people are our allies. We will never, ever, ever win this without our allies. And I think it's really important that that's not just an idea that's floating out there that we accept intellectually. I think it's really, really important for the single-payer movement to take that and actually act on it. And by allies, I mean both groups who formerly put a lot more energy into fighting for single payer, and in the last few years have shifted their energy to work on the ACA, passage and implementation and defense of the ACA. I include both those groups, as well as groups who may not be actually that familiar with single payer, but they're healthcare groups or non-healthcare groups, but groups who share similar values, and they should be our allies. So I'm including a big tent of folks. We will never, ever win without them. And again, I think the state single-payer campaign is a very, very good way to find common ground and work together. Last year, after the Supreme Court decision came out, I thought it was a good time to reach out to some of our allies. And it was very, very important to many of our allies to defend the ACA and around the Supreme Court decision. So my board chair, Dr. Oliver Fine, and I, it was a small meeting. We reached out to a number of groups. Doctors for America, some of you may be familiar with them. They started their life as Doctors for Obama. National Physicians Alliance, a progressive physicians group, started just maybe 5-6 years ago, but nationally they have about the same number of members as PNHP, and they may be, so it's an important progressive physicians group to connect with. CIR, SEIU, that's Committee of Interns and Residents, Medical Interns and Residents, they're part of SEIU. And Community Service Society, which is a group in New York who, one of the leaders there, Elizabeth Benjamin, she's a very well-respected healthcare advocate and also leads a coalition of 100 groups. So these are our allies, and all of them individually, I think except for maybe the representative from CIR, all the others were individually members of PNHP. They believe in single payer. They also decide that the ACA is something they want to fight for. Some of us may disagree on that, but we have so much common ground. And that's what that meeting was about, and we're very clear about it. Like, we understand that we may disagree on the ACA, but let's find common ground and work together. And we proposed 3 things to work on together. One is the New York State single-payer campaign. The second one is Medicare defense. And the third one was the exchange, thinking about how to have a more progressive exchange. And they were very positive about our suggestions. And we then proceeded to work on those things together. I think equally important as those specific projects, it was the idea that we reach out to them, and then we said, we know we have a lot of common ground, let's work together. And some of them just specifically told me that they were very pleasantly surprised that we reach out to them. So then soon after the meeting, we started our chapter. Our research director, Dr. Len Rodberg, drafted, along with another board member, Robert Padgug, drafted a number of recommendations for the exchange. And the frame that we use is how to build a progressive exchange that maximizes its potential for eventual transition to single payer. That's essentially what Vermont is doing, right? Before they get the voucher in 2017, they have to build an exchange by law, but they know they want to transition to single payer, so there are ways to build the exchange to make an easier transition. Now, people have different feelings about this, and there are people who feel, I don't like the exchange, I think it's a bad thing, and you can't say that you can make a good bad thing. There are people who feel that. We do feel that this is what all the other health advocates in our state are thinking about and working on. We are not a part of the conversation because we say A, is not single payer, and B, some of us don't like the exchange and therefore we don't want to think about it. So by saying that, we are telling ourselves we don't want to have a seat at the table, and we don't want to be a part of the conversation. That's why these folks were pleasantly surprised, because we broke that idea and we did want to work together. So we drafted those recommendations and quickly got about 30 groups signed on, including 20 that came from that coalition that I mentioned. That was led by one of the leaders in one of these allied groups. A few months after that, we were working on Medicare, a Medicare defense statement signed on by physicians and nurses groups. We thought it was important to have a statement specifically coming out of healthcare providers. And again, we reached out to them and worked on that together. And a statement was eventually signed by groups representing, I think, somewhere around 270,000 doctors and nurses. So, and it was important to know that during these projects that we worked together, there were sometimes tensions and disagreements about how much the statement should talk about Medicare for all, right? Because other groups might feel like, well, this is about defending Medicare. Why do you have to insert Medicare for all in there? The reason is obvious. It's because that's our sole mission. But it is not their sole mission, right? This goes back to exactly that. We will never win without them. It shouldn't be us and them. But sometimes they're 24 hours in a day, and we all make decisions about what we're working on. So sometimes there's this idea that is us and them and what they're working on, we're working on. So even though other groups support this idea, if quote unquote, we never work on quote unquote their issues, how do you expect it to go in the other direction? So we very respectfully tried to work out these differences. To the extent that we had to delay, we were going to do a breakfast with reporters to coincide with a visit that President Obama and Mitt Romney, the candidate, were making at the time when both parties were saying very scary things about what they would do to Medicare. So we had to delay a public event that we were going to have because of some disagreements we wanted to work out about the statement. And I think we completely made the right decision. I think our relationship with them and our willingness to work together, we have our positions and our beliefs, and we stand our ground. But it's important that we understand their concerns and work together. So we ended up actually not having the press breakfast at all, and we released a statement much later. But I think we made the right decision. It's important that we really rebuild and strengthen these relationships. And then lastly, the state bill, lastly in terms of our combined projects. So I'm very, very happy to report, as of about 36 hours ago, I just heard that Doctors for America, New York State, has endorsed our state bill. So, and that, that came out of what we've been doing together for the last year. And a week prior, National Physicians Alliance New York State endorsed the state bill. And it wasn't that much hard work. We have been talking about it informally for months, and then I sent an email, and it was a very smooth process, and I'm very happy to report that. Another quick story about working with allies. We were part of a mayoral forum Mayoral Candidates Forum on Public Health. That's not a single-payer issue. Why do we work on it? We actually originally weren't particularly invited to be a part of it. But CIR, which is part of SEIU, and they're one of the groups that I just mentioned that we are rebuilding and strengthening our relationship with, they invited us to be at the table. We were. Throughout the 4 or 5 months of planning, we repeatedly wanted to, of course, inject single payer into the planning of the event. We didn't end up getting a single payer question in for the direct questions for the mayoral candidates at the forum. And at first, that was maybe a bit challenging because that is our issue. But at the same time, it's very important that we are at that table because so many important groups working on public health issues in New York City, they were all there planning this together. So just 3-4 nights ago, I ran into a representative of one of these organizations, one of the main organizations, just on the street. Completely unprompted, she said, "Can I just tell you how important it was that you guys were there during those 4 months of planning? Can I just tell you that? Because you were there to keep pushing, and you allowed that political space to be expanded. And even though virtually everybody there, varying degrees of commitment, probably, support your cause, everybody has been working in what is considered the realistic political mainstream. But your being at the table was very important. You reminded us what we actually ultimately want, and I just want to thank you for that." So, okay, I know. Need to finish up, sorry. Lastly, constituents, all of us, right? Again, going back to that sense of the possible, without that, we are not gonna get anywhere. And working on the state campaigns, besides the fact that we want actual legislative victories, of course we want that. We want to actually pass single payer in New York State. We want to actually pass single payer in Ohio. But before that happens, it gives your constituents and yourselves a sense that this is doable, this is possible, and it helps propels the whole movement forward. And I'm going to close with one very, very quick story. I organized a meeting with the co-leader of our state Senate. He's a Democrat who's caucusing with the Republicans right now. And I called up, again, people in my database, many of whom I had never met, just because, 3,000 people. And a large number showed up, medical students and physicians. And at the end of the meeting, I handed this physician, who's a prominent physician. He's the former longtime chair of medicine at a prestigious academic medical center. I handed him a postcard of the event we were doing that month. We have monthly forums. And he said, "Oh, no thanks." And this is after the meeting with Senator Klein. "No thanks, I don't go to those. As you may know, I have not been active with your group for 10 or more years. Because you know what, I just didn't see how we're gonna get there. And with the passage of the ACA, I just kind of gave up. But then you called me up and said that this was happening locally, and this was happening in the Bronx, and that we're gonna meet with the state senator that represents a hospital where I worked for 15 years leading the Department of Medicine, and you told me we are 2 co-sponsors short in the assembly to pass the bill. I'm there." He actually just emailed me last night asking about, how the campaign is doing. So that is why we need to work on state single-payer campaigns. And lastly, I just want to say, I spent 6 years of my childhood in Columbus, Ohio, so thank you for welcoming me back.
Thank you, Lori. Our next speaker is Mike Shea. And, that old saying, make new friends but keep the old, one is silver and the other's gold, and Mike is definitely gold. Mike has been with SPAN before. He has helped develop a strategic plan for SPAN, and there were a couple of times in this past year as state director when I was tearing my hair out, and Mike helped restore my sanity. So thank you to Mike. Mike Shea.
Good morning. So I got a logistical problem, which we'll solve. Is that a remote mic? Can I use that so I can walk around? Do you mind if I walk around? I'm nervous, so
No.
No, it's true. I'm sorry? Will you have trouble if I walk around a little bit? Okay, well, if I stay in this area, will that be okay? All right. All right, thanks. Okay. I just got here already. Is that on? No. Let me switch mic. Is it on now? Well, fine, now what? Hello? Okay. I just got here already, I'm a pain in the ass, so thank you. I do too. It's new. Could you tell? So I have a PowerPoint only because gold rhymes with old. I'm old, I forget. So it helps me to remember. So I know you can't see it in the back. That's okay. I'll read it and we'll go from there. So like Lori, I have some connections to Ohio. I graduated from the University of Dayton in 1973 and then lived another 5 years in Dayton. So thank you, UD, for a decent education and a great experience. And anybody here from Dayton? All right. Wow. Nice to see you. Just a couple demographics here. How many here are either current or former healthcare workers? Wow. That's terrific. Okay, I've got some stories for you folks, all right? How many here are either in the past or currently under care? Oh. Okay, that's good. So anybody here besides me, under care? All right, under care? Has been recently under care? Don't care? Okay. All right, so let's go on. Yeah, that's okay. If people want copies of this, we'll get it.
We want to see you.
You're my new best friend. All right. So let's go. I didn't mean to start all this trouble. So I've been asked to talk about what the impact has been of the Affordable Care Act on healthcare workers. So the last time I was here, I was a partner and a principal in a consulting firm that did a lot of work with unions around the country. I come out of a textile mill as a worker. I'm a former shop steward, former president of my local, and a former union organizer with the textile workers and the Amalgamated Clothing and Textile Workers. And Ben and I have known each other a long time. And then I left the union and went on to graduate school and into consulting. So I didn't have to say that before, but I have to say it now. Now I'm an employee of the Training and Education Funds of 1199, a healthcare workers union based on the East Coast. Primarily headquartered in New York City, but ranges from Florida up to New England. So the remarks I'm making today are not based on my relationship with 1199. They're my individual opinion. I just want to be clear about that, okay? So, having made that disclaimer, let me move on. 1199, and in my experience as a consultant over the past 3 years, I've had the opportunity to go into 6 major hospitals, 3 in affluent communities, 2 of which are major medical school research facilities, 3 of which are in extraordinarily distressed communities. I've been in about 15 significant, meaning more than 300-bed long-term care facilities, and as well as in large operations of home care agencies. I've had the opportunity to do one-on-one interviews and focus groups with hundreds of healthcare workers. And I want to bring you some of their stories because a lot of their stories talk about the impact that the Affordable Care Act is having on them now, and that impact will intensify shortly. But before I do, and in fairness, I want to set a context for this. The intent, as I've read it, of the Affordable Care Act, and I don't impugn anybody's integrity, the intent was to improve healthcare outcomes, improve the patient-customer experience, and reduce the rate of healthcare cost inflation. That was the intent as I've read it and as it was publicly announced. So where's the clicker?
It's on the edge of the table right there.
Thank you. So, under the new federal law, the intent, yes, I can. Next year, maybe I can't do this, but this year I still can. All right. So, the intent of the new federal law was to reduce uninsured from about 54 million currently to 23 million. Now, what I find interesting about that is that's a huge success, except if you're one of the 23 million. I just want to point that out, improve senior access to health care and lower the cost of care. Increase coverage for pre-existing conditions. I don't want to shortchange that. We've had way too many members can't get coverage when they lose their job, go for a period of time without coverage, and then find employment but can't get coverage because they're diabetic or they have other chronic health care conditions. That's no longer allowed. Increase more affordable coverage for individuals and small businesses. And I have children who have benefited from the fact that you can now cover them to age 26. I appreciate that. Okay. Now, it also affects or impacts reimbursement rates for hospitals. There's a penalty for hospital-acquired infections that's substantial. There's also penalties for 30-day readmissions and other outcomes. It gets kind of technical. Did I just lose this? I'm trying. Put it, maybe I have it back. There we go. All right. So one of the other aspects of reimbursement is for HCAHPS scores. Anybody here ever hear of HCAHPS? Okay. So Health Consumer Assessment of Healthcare Providers and Services. Systems. Thank you. You're paying attention. All right? Basically, what happens is every time somebody's discharged, in the mail they receive a survey that some 15% or 13% fill out. There's a 1% give back of CMS reimbursement that's held kind of in escrow. And you can earn that back depending upon certain outcomes and certain HCAHPS scores. Then, that's in 2013. 2014, it'll be 1.25% until it goes up to 2% in 2017, plus other penalties associated with outcomes. Now, it's easier to get good HCAHPS scores, as I understand it, if you're a hospital in Cheyenne, Wyoming. It's a little more difficult to get great HCAHPS scores if you're in Cleveland, Toledo, Cincinnati, or maybe even Columbus, depending on the part of Columbus you're in. It's easier to get good HCAHPS scores in New York City if you're a hospital in the affluent Upper West Side. It's a little more difficult if you're in the Bronx, or in East New York, Brooklyn, where you have much more difficult populations. So you take this issue of having distressed, this is really, all right. I don't want to take time to go over the technical parts. That is so nice of you. I would press this one. Yeah, thank you. Thank you very much. This issue of reimbursement is incredibly important to healthcare workers. Go ahead, next slide. What's the impact? So the intent is one thing, but what's the real impact? The impact on healthcare workers is that declining reimbursement disproportionately impacts those with the least influence within the hospital, the post-acute, or the long-term care systems. So, for example, right now, all across the country in major urban areas, there has been significant shutdowns of hospitals in distressed communities. Make sense? Does it make sense? But that's the impact. Declining reimbursements, causing healthcare facilities to shut down, and the communities that have the least choice and the greatest need. Long-term care facilities in distressed areas. There's a fire sale going on in the New York City area of not-for-profit long-term care facilities. Facilities that were started by the Jewish community, by the Catholic community, by the Lutherans, by the Episcopalians, and just kind, decent people. Under the current systems of reimbursement, declining effective reimbursement, these facilities are going bankrupt and being forced to sell out. Now, apparently, there's still money to be made because entrepreneurs and investment bankers are buying them. Now, sometimes they're buying them. Coincidentally, some of these facilities sit on prime real estate. You know, I'm just naturally cynical. You know? But some of them are purchased to be run because they can be profitable. But how's that profit made? Next slide, please. Declining reimbursement disproportionately impacts those within the least influence: nurses, RNs, nurses assistants, CNAs. I was a nurse's assistant for 3 years. That's how I worked my way through school at Dayton. There's a small private psychiatric facility on Salem Avenue. I don't know if it's still there or not. I worked there nights while I went to school during the day. That's how I fed my family and paid for my education. They can't, pardon me? It was Dartmouth. Is it still there? Not sure. Okay. Well, I have some stories about that, but I don't want to be recorded on that. Social workers, support staff. By support staff, I mean dietary, housekeeping, admin, transport, maintenance, and others. All right, next slide, please. So I've already described that. I'm going to tell you some stories from those interviews and those focus groups. Next one, please. Next one, please. All right, here's a story. This was from a nurse. We have gangs, drugs, and violence in our community. Because the security department is short-staffed, there are frequent delays when security personnel is requested, resulting in staff working in really unsafe environments. Another consequence is that security personnel often request the assistance of non-security staff to restrain violent individuals. We can't keep our staff safe, much less our patient. That comment was repeated by other nurses, by housekeepers, and by security personnel themselves. I assure you, this hospital was not located on the Upper West Side. Okay? So the question is, why don't these two hospitals have the security staffing they need? Why? Because they can't afford it due to the reimbursements. And those reimbursements are going to decline. You take a difficult situation, and the impact of the Affordable Care Act is going to make it worse. Patients complain of being cold, but I cannot give them additional blankets because we don't have any to give out. Many of the ones we do have are ripped or have holes. It's embarrassing. Okay, so I'm a patient in your hospital. Something about getting older makes me more susceptible to cold. I used to shovel snow in shorts and a t-shirt, you know? Now I get cold all the time. If I was in the hospital, I've been in the hospital, I want a few extra blankets because that gown you gave me just ain't doing it. Right? And you tell me, Mike, I can't give you any. Really? Do you have any idea how much my insurance company is paying for me to stay here? Blah, 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 you know. Then I go home and I get the HCAP survey. Give that baby to me because I got a few things to say. That's going to make their ability to get more blankets, how? Worse. Okay? Patients or their family ask for extra pillows, and I have to tell them, bring them from home. We don't have any. And oh, by the way, I'm going to send you an HCAP survey, and please be good to us. Okay. Next slide, please. Long-term care facilities in the state of New York average a loss of about $6 per Medicaid resident day based on 2011 figures. Now, that doesn't sound like a lot, but if you have a 500-bed facility and 80% of your residents are Medicaid recipients, do 400 times $6 times 364 days, that comes out to about $874,000 in cash off the bottom line. So what happens if we put more people on Medicaid? We lose more money. Tell me how this is helpful. Tell me how this is helpful. All right. So, next slide, please. One of the things that folks say is that we have to grow our capacity to care for people in our homes. I agree with that. But under the current reimbursement system and under the current reimbursement levels, we do not pay home care workers very much. As a result of not paying them very much, a lot of agencies experience over 100% turnover per year. Now, you put that fact together with the research that says that qualified, experienced people engaged in consistent assignments. Consistent assignments means I go and visit the same person every day. I get to know that person. We develop a relationship. It's not just about physical comfort, it's about emotional and spiritual comfort as well. I know this patient. I know when this patient is out of sorts because we've developed a relationship that's based on trust and affection. How do you establish qualified, experienced people engaged in consistent assignments if you have 100% turnover? You don't. You don't. Next slide, please. Our patients are on a 5th floor or 4th floor or 3rd floor or 7th floor walk-up. Do you have walk-ups in Columbus? Walk-ups means there's no elevator. It was built so long ago, there's no elevator. You have to walk up the steps. See how that language fits together nicely? How do you if I'm a home care worker, and basically in our area, most home care workers are female. A lot of them are first-generation immigrants. And a lot of them are 40-plus years of age. How does a home care worker working alone get that patient down to the street level for their appointments?
They don't.
They don't. They don't without getting hurt. And then they need home care. You're right. Okay? Next one, please. This one, I had a man who's a social worker crying by the end of our interview, who said to me, managed long-term care companies are pressuring us constantly to discharge patients before we can find them safe placement. They don't care. They just threaten to cut off paying, saying the patients are no longer making medical progress. I don't want this place to go bankrupt, but it kills me to violate my beliefs and the ethics of my profession. I hate this part of the job. Each healthcare worker, almost to the person, talks about they love giving care and they love the organization they work for. Very loyal to the organization they work for. But the stuff that they have to do or work with or not work with, they hate that part of the job. Next slide, please. If we want to get paid, we need to discharge when the managed long-term companies demand. If we're going to do that, then we have to start admitting patients on the basis of ease of discharge, not on the basis of whether or not we can help them. If we want to get paid and we don't want to get bankrupt, we have to evaluate a patient coming into our post-acute care facility on the basis of the ease of discharge. Otherwise, they're going to stay here for days because I'm not sending them into an unsafe environment, but we're not going to get reimbursed for those days by the managed long-term care company. If we do that too often, the facility goes bankrupt. Especially the facility is associated with a long-term care facility. One of the ways that the long-term care facilities can afford to provide care for Medicaid recipients, even though they lose money per resident day, is to subsidize those losing operations with the operational profits from post-acute care. And if that post-acute care operational profit diminishes, then we can't subsidize the Medicaid recipients. Ladies and gentlemen, the impact of the Affordable Care Act takes none of this impact into account. Next slide, please. So think about you getting your HCAP survey. You get discharged from a hospital, go into a post-acute care facility. You're scared because it looks a lot like a nursing home. You're scared you're not going to go home. Your family is scared for you. For some reason, you were discharged at 7 o'clock at night from the hospital and they didn't feed you. You come into our facility and we welcome you. And you and the family, and it's in a distressed neighborhood. It's not a safe neighborhood, but our place is safe. And you say to us, we're hungry. And we say to you, tough. Well, we don't say that. We usually say is, I don't know why they closed our cafeteria and the kitchen's closed and we got nothing. What do you mean you got nothing? And so what do you think of the first impression? And how does that relationship spiral downward from there? You've already set up a confrontation between the staff, the family, and the patient. But why do we shut down the cafeteria? Why do we shut down the kitchen? Because we had to sub it out, and the company we subbed it out to, under cost containment, shuts it down. So you get the stories. Now, I want you to understand that the staff wants to be able to give great care. Last week, I was consistent with these stories. There's this great report called Through the Eyes of the Workforce, Creating Joy, Meaning, and Safer Healthcare, put out by the Lucian Leib Institute, and it's a report from the Roundtable on Joy and Meaning in Work and Workplace Safety. I just want to read a couple of quotes of this. I'm at that awkward age where I can't see you without my glasses, but I can't read with them. Production and cost pressures have been building in healthcare for a variety of reasons, not the least of which is a reimbursement system that pays for production and transactions, thereby reducing complex, intimate caregiving relationships into a series of demanding tasks performed under severe time constraints. The basic precondition of a safe workplace is protection of the physical and psychological safety of the workforce. Both are conspicuously absent or considered optional in many care delivery systems and organizations. Disrespect of workers is manifest in poor treatment. Poor treatment because I can't give the care I'm passionate to give, because I don't have the supplies and I don't have the systems, the support to do that. And it's not because people have a secret Swiss bank account. I'm convinced of that. It's because of the pattern of reimbursement and this consistent decline in reimbursement without thinking through the intent being to lower the cost of healthcare inflation without thinking through the impact on those with the least influence within our society or the healthcare system. I'm not afraid of the Affordable Care Act. I welcome it. I welcome the positive that it gains, because I believe that its weaknesses will become apparent, especially if there's folks out there like you and us, folks in New York, folks in other states, who will find these stories, create the forums to share these stories, and create the passion, because expectations have been raised. Those expectations will not be met. And you have a solution. And that solution is what? Okay? So the intent of the Affordable Care Act is to move from an economic business model that says flexible price plus cost equals operating profit, to a system that says fixed price minus cost equals operating profit maybe. Where does that cost come from? Most systems start by addressing the least powerful. That's the impact, the difference between intent and impact. Find these stories, share these stories, reinfuse the passion in this discussion, because the disappointment is coming. Thank you. Yeah.
Mike, can you clarify ACA, what does that stand for?
Affordable Care Act.
Okay. Yeah. We are going to take a few minutes for questions, so I will try to keep my eyes open and get around the whole room. Yes, please.
Hi, Mike. Kathleen Geminer, UCAN, Ohio. Can you break apart a little bit the impact of declining reimbursements from the various sources? I mean, because we've got insurers squeezing hospitals, we've got many different sources. In terms of the Medicaid budget, states, control that budget. So I would like to see if you can separate out which things are actually ACA related and which things are part of a whole trend that has happened irrespective of the ACA.
So declining effective levels of reimbursement going through inflation have been declining for a long time, since probably the late 90s. It's all interrelated. It's virtually impossible, at least for somebody like me, maybe I'm sure there are smarter people in this world who could do this, to tease out, to extrapolate out as independent causes each of the variables that you talked about. Because what happens is, as CMS, the Center for Medicaid and Medicare Services, starts to reduce its level of reimbursement, states have to pick that up. State budgets are under distress. They take their cue from CMS. They reduce their budgets. Insurance companies look at what CMS and states are doing, and they reduce their budgets. Because what happens is that many hospitals and long-term care facilities will compete for the private pay or the private insurance. The private insurance companies quickly learn. They're smart. They've got good economists working for them. They quickly realize that their reimbursement levels are substantially above the reimbursement levels that come from the public sector. They're not in the business of being generous, so they reduce their reimbursement levels to cover that gap, to close that gap is a better phrase. So where one starts and where one ends is difficult to understand. What the Affordable Care Act does, however, is take that concept and not only talk about reducing CMS reimbursement, but this whole idea of penalties. The intent is to improve outcomes and the intent is to improve the patient experience and customer service. The impact on healthcare workers, because in a long-term care facility, probably, and I had the exact number, but probably about 80% of the cost is staffing. So you begin by reducing staffing, and then you begin to reduce compensation and benefits, and then that leads to increased turnover. That increases your recruitment, retention, and training rates. That's less money that you have to spend on staffing, and it becomes an ugly spiral. So in some ways, they're all interdependent and interrelated. I hope that makes sense.
I disagree, but I understand.
Okay.
A number of us have gone down to come down to Columbus before to increase to get the Medicaid expansion passed. And in light of what you're saying, where is that money going to come from to pay for all this Medicaid expansion?
I don't have a complete answer. I have a partial answer. So part of the of Medicaid expansion comes from taking operating profits away from insurance companies and using that money to pay for part of the expansion. Part of it's got to come from increased taxes. Part of it's got to come from a more efficient system. Right now, we have and I'm sure there are people in this room who can better answer this question, but we have a terribly inefficient system. In distressed communities, the primary provider of medical services is the emergency room. When you go into the emergency room with an emergency because you're in a diabetic coma or you've had a stroke, the care is expensive, but that doesn't equate to the fact that your life is in danger. If we had a more rational system of health care where we had community outreach, community health care education, better primary care and preventive care, the ability to educate people to manage chronic conditions more rationally, the money that's currently being expended on emergency room care and treating those catastrophes could be put into allocated for Medicaid expansion. So part of it is about developing a more rational system, part of it's about reallocating, and part of it's about increasing taxes. I don't want to be afraid to say that.
Logan Martinez, Dayton, Ohio. Part of this money, and the way I've read the articles about Medicaid expansion, is going to come. The federal government reimburses hospitals for the uninsured, and they're taking that money, so I think something like $14 billion here in Ohio, and shifting that to pay for, or possibly pay for, Medicaid expansion here in Ohio. And so that shifting is going to put a burden on the hospitals. As you point out, there's going to be still a large number of uninsured people, and the money that the hospitals got to take care of them is not going to be available in the same amount. My question and point to both of you, we work with a number of networks. I primarily work with unemployed and low-income people, and we've been working quite extensively on Medicaid expansion here. And it seems to me there has to be a link across the board on these issues for us to strengthen our impact. And I've written a little proposal I've passed out, and I'll have more copies for people. But as you pointed out in your presentation, Laura, was that I think we have to fight for health care in the here and now, such as Medicaid expansion. We did not work on the Affordable Health Care Act because it wasn't worth, I felt, putting the effort into it. But because there is some net gain for poor people potentially, I think it's a fight that we have to fight, and I think SPAN needs to be in the forefront, and we had an action in which a number of people from SPAN were at. But the other part of this is across the board unity around issues like jobs and peace and the broader progressive agenda, that we are in a boat that's sinking, and we really need to link these things together and fight for them. I'd like for you guys to share what you think of that.
I think that's a very important question, in organizing, to do the calculus of how much resources you have related to how much impact you think you can have, and then what you're going to gain from building relationships with allies on issues that are not specifically single payer. And I think it's important to be pretty hard-nosed about what am I going to gain from this? What is my organization? What is my movement? And that's really not meant to be cold-blooded. It's about being effective. So it is very tricky because in really every single payer group that I know of is filled with people who care about environmental justice, peace, many, many issues. At which point are you losing focus and effectiveness because you want to work on everything, right? And say, well, but those are allies and we all believe in this anyway, so we should all work together. That all sounds great, but most single payer groups I know are also we're not as big as we need to be. We're nowhere near as big as we need to be. We have limited human and financial resources. So I think it's a very, very tricky calculation that each group makes in each context. I do believe that Medicaid expansion, when you do that kind of calculus, it's like, okay, who else is working on it? How much resources does my group have? And how much impact I can have on this particular issue? And what we're going to gain from working with these other groups. The calculation that I make for that particular situation is that it is worth it because it's focused enough, specific enough to our goal of single payer. And when you look at who is working on it, it's likely that many of these other groups either theoretically support single payer but may not work on it, or at one point really worked on it, or in that category of very, very useful allies. So in that case, I think is very much worth it. And then I think in terms of impact, Medicare defense, that's a very obvious thing for supporters of improved Medicare for all to work on. If the foundation of what you want expanded to everyone is going to crumble, you're not going to have what you want. But let's say if we take the New York Metro chapter of PNHP, how much impact can we have on Medicare defense, on defending Medicare nationally? And it's very difficult for a local chapter to have an impact on such a big national issue. So I think for my chapter, in deciding how much effort we put into it, we look at who else, who is bigger than we are, is working on it. We assess what they're doing, and we want to connect with them to do what they're doing. So we're not necessarily the ones taking the lead on it because we understand it's actually unrealistic that as a local chapter, we can have a huge impact on this, against this tidal wave of attacks on Medicare, right? So if we were to spend a huge amount of energy creating initiatives and trying to take the lead on it, it would not be a very smart move, right? So we look at that, we understand our limitations, we look at what other groups are working on it. Unions are working on it, right? SEIU 1199, right? And other groups. So we want to piggyback and be in coalitions that are working on that. So in New York, there's a coalition called the No Bet Grand Bargain Coalition. So we are part of it. We take a lead on certain very specific concrete things, like we took a lead on organizing several meetings with congressional representatives because either we already had relationships with them or we had board members who are in their districts, right? But the larger coalition, there are a lot of groups with a lot more, with bigger muscle doing the bigger stuff. So I think the key is to look at each situation and look at your group and make this calculus so that you are not mired in putting a lot of time and effort into things that your group actually doesn't realistically have a lot of impact on, but because you feel like there's this idea that you can that number one, you believe in it. Number two, you want to reach out to the allies. But you do have to be maybe not ruthless, very careful in deciding so that you don't end up doing 10 things and not really achieving much in any one of the areas.
I only have one thing to add to what Lori said, because I completely agree with her. And that is that on the 1199 Union Building on West 43rd Street, New York City, where hundreds, if not thousands, of healthcare workers go in and out of each day. Transporters and housekeepers and nurses and dietary workers, home care workers. There's an incredibly beautiful mosaic above the entranceway. And it has this phrase: without struggle, there is no justice. So nobody's going to come along and give it to us. People have to fight for it. But as Lori said, that fight has to be both effective and smart. So trying to figure out where I have, or my coalition, or I as part of an alliance, my organization, has the most influence on the topic that I have the most passion around, that is core to our vision and core to our values and core to our mission. That's where I put the bulk of my energy. What I have left over, I do other things with.
Just to add to that, this goes back to why our chapter made the decision to put so much energy on the state campaign. We can have, and we have been having, a huge amount of impact on the state campaign. We are leading the state campaign in New York, for all the reasons that I detailed earlier. And we knew that we could lead it and have the amount of impact. We are the ones reaching out to allies to get on board, right? And it's been, I think that's a very good example, right? These are the two things: the New York State campaign and National Medicare Defense. They are, in theory, equally important to us. But when you look at, we knew that we could have a lot more impact on the state campaign, and we act accordingly. And with Medicare Defense, we look at our allies and we work with them and let them take the lead. And of course, with a group like PNHP, because we are a physicians group, our resource is, our members are physicians. So when there's an event and they want a bunch of people in white coats, I know that I can help with that, right? So maybe we're not the one working on a lot of the other parts of the campaigns, but know your power, know your resources, and use them smartly.
Thank you, Dallas. My question is to Lori. You mentioned about targets, allies, and constituents, okay? Being a constituent, okay, when you talk to your congressman, legislator, or whatever, you try to get their position, okay? We do that. But when it comes down to time to vote, their vote is contrary to what you was talking about. And I will just go back to this series on the gun debate. About 90% of the people were against, for gun control. And what happened when they had that vote? Okay, you can see how much they're worried about their constituents and about what's happened in this country. But we never researched the candidate, some of us do, the candidate's positions before he's running for office, what he really thinks. Most of them are voted by popularity, by the name or whatever. So we have to go back to researching what they really stand for. Thank you.
This is, I guess, kind of a comment, and I'd like to encourage everybody when people ask about Medicaid expansion, why can't we call it Medicaid reorganization? Why can't we call it, let's let people who are working and want to stay married and keep a family intact, why can't we call that Medicaid reorganization and not Medicaid expansion? Because everybody gets the wrong idea that we're just going to try to get everybody into some, the system we have now, which is horribly dysfunctional, full of holes, and pathetic.
I'm David Weaver. I'm a slacker from Columbus. I'm glad you work at the psych hospital and that you're a physician, because I need to be kept in touch with reality. It seems to me that the Health Care Act and the Affordable Care Act are actually insurance acts. I don't think that's going to get me healthy. So, people are power, that's what we got. The majority of people will go with us. Where are these people? Well, they're not here because we don't communicate with them and they don't know what to do. So we got to recruit and we got to focus our efforts. I really like what you say about your focus. But I think we got to focus on recruitment. We got no organization. Sorry. I'm surprised the SEIU is in this, but other than them, I know of no unionization. We're not unionizing the people who need the health care. So let's do the Jenny Craig model. Small groups, which then break off into more small groups. Eventually you recruit everybody. You don't need money. You don't need leadership. It just spreads. Thank you.
Hi, April Stoltz. Real quick, two things. I just wanted to say, Lori, thank you so much for your message. I think it's a very powerful message to be talking about allies. We've got UCAN in the room today. I mean, thrilled to have all these other groups in the room today. Thank you, Debbie. You've done incredible work at building bridges. Sister Lori was right. It's all about building these bridges, right? So thank you so much. So here's my question. My question is this. Mike, I hear what you're saying. You're talking about being ready, and you gave us some important stories. Now, this whole healthcare thing is very, oh my God, there's so many moving parts, right? There's so many layers, there's so many moving parts. So when I'm out here and I hear people talk against the Affordable Care Act, it's like if I don't know enough, I might think you are one of these folks that believes all the lies that are on the radio, right? And I know you're not, brother. So here's my question. How do we build that bridge to be able to be critical in a way that doesn't make us sound like we hate the Affordable Care Act? I mean, I always say it's the first step in the right direction. I think probably a lot of us in this room believe that. So what I want to ask is, how do we do what you're asking us to do and not sound like we're a bunch of antis? Okay, there, that's it.
I have to do a better job of speaking. A, I'm not a physician, and B, I don't support the bulk of the Affordable Care Act because of the impact. I do respect some of the intent, and I think the way, I mean, I've been framing the story of the Affordable Care Act about differentiating between the intent and the impact, and so far I've found that to be compelling. To give credit for the goodwill of the intent and discuss the impact in a way that's so compelling, people ask, what else do we need to do? Because it's not working. You know, I'm of the opinion the effects have not yet been fully felt. And when the effects are more fully felt, we're going to have a group of people who are disappointment, and disappointment can be turned into anger, and anger can be turned into the ability to mobilize. Sorry for being cynical. I'm not sure that's cynical, that's being an effective organizer. Find the reason that people are passionate, give them a channel to exercise that passion, and give them a direction. And they'll do the rest on their own. So I'm sure there are different and even more effective ways to frame this story, but I try to acknowledge its success, demonstrate its impact through the stories that are indisputable, and then appeal to a person's sense of justice.
My personal position and the position of my chapter is that A, the Affordable Care Act is the law of the land. B, people want to find out and want to understand how it's going to impact them. That's the conversation that individuals as well as organizations are having. These individuals and organizations often don't see working on state single payer as contradictory to supporting the implementation of ACA, whereas pushing for national single payer is a more difficult conversation. People do perceive it as contradiction. And I'm, again, not saying that because of that we are not talking about or working on national single payer. We are. But in terms of how to have that conversation and get the foot in the door, we have found it very, very useful to simply acknowledge my organization may have a different assessment of the ACA than you. But let's find common ground. I mean, it's exactly how I described that meeting, right, with National Physicians Alliance, with Doctors for America, with CIR, SEIU, with all these groups. And we're honest about it. We believe in or believe. We know you may believe something differently. We know we still have a lot of common ground, and let's work on it. And in our attempts to get these groups' endorsement of the state bill, and I just told you that we have been successful, in that conversation, we often do get the answer, well, okay, I support this idea, but can you tell me a little bit more about how you're conducting the campaign? How are you talking about the ACA in this campaign? You know, are you saying things that we're going to disagree with in this campaign? Because that wouldn't be very fair, is the implication. And it's true. It's true it wouldn't be fair. So my response is the following. I tell them how we're organizing one of our town halls. As we get more and more co-sponsors in the state bill, and as I mentioned earlier, we are just 2 co-sponsors short in the New York State Assembly to pass the bill. Right? So the Senate is a much harder fight, but we have 74 in the Assembly. We just need 76. We have 75, but one had to resign due to a corruption scandal. But we're so close. We're so close, right? So when we're talking to these groups, so as we increase the number of co-sponsors, we still want more, of course. We are having repeated meetings with with legislators who have already signed on. And one of our demands is that they get more active. And one of the very concrete things we suggest is do a town hall in your district. We want your constituents to know you're taking leadership on healthcare. It's very important to them. And we want you to educate them, and we will help you do this town hall. So we are organizing among different things to push the bill, one such town hall in East Harlem with Assemblyman Rodriguez. And what we actually proposed to him was, we know people in your district are wondering what this federal healthcare reform law is how it's gonna affect them, and people are gonna wonder what's happening with Medicaid, Medicare, and other things. So we propose that we start with a patient story. If you can have your constituent, one of them, speak about his or her personal story, and then we propose a 20 to 25 minute. That's the biggest chunk of the town hall. We will get an expert to talk about the Affordable Care Act. And who do we invite for that? We invited someone from CMS, from the Center for Medicaid and Medicare Services, to talk about the Affordable Care Act. If our intent were to just put it in a very negative light and then come and save the day and say, well, single payer is going to solve all that, we would have invited a different person. But we knew that the audience for that particular town hall is going to be very, very, very new to this. So they just needed some answers about how it's going to affect them. Right? So it's not a positive or negative thing. It's somebody from Center for Medicaid and Medicare Services who knows the details of how it's going to some of the impact. I'm sure they will not actually end up going to the impact that you were talking about, which is also part of the ACA's impact. And then we're going to do a single payer 101. And then we're going to talk about the state bill and get some people on the bus for our lobby day coming up. All right, so I respond often by telling our allies, if you're worried about how we're conducting the campaign, look at how we're doing our meetings. We understand the ACA is the law of the land, and people are curious about it, and it's a way, and people are having conversations about it, and it's a way for us to be a part of the conversation.
Okay, we have time for maybe 3 more questions. There's a question back here, Dr. Rant, and then Rachel, and then we will have lunch, okay?
I'm Tom Pretlow. I'm a retired physician and professor from Case Western Reserve School of Medicine. And I would just like to caution people about generalizing about our healthcare facilities. If you've got a care facility that has 80% Medicaid patients, you've got a problem. There's plenty of money out there, though. If you look at University Hospitals and Cleveland Clinic, they've got money coming out of their ears. I, back about 10 years ago, got University Hospitals' tax report when they became available for the first year via congressional law. I looked at their tax report, and I was amazed. They had 2 pages of contributions to the Cleveland Ballet, Cleveland Symphony, Hawken Private School. They're much harder to discern now because when you go on and look at their tax report, they've got 13 of them now. I only opened one last time I looked, but my attention was caught in that one by $1 million spent for lobbyists. This was itemized and labeled as such. They didn't even try to hide it. I live in Shaker Heights. Shaker Heights has just had its centennial or whatever, and University Hospitals just donated $25,000 to help Shaker Heights celebrate its centennial. How embarrassing. I mean, what patient is going to lose their car because they can't pay the bill so Shaker Heights can have a bigger centennial? It's a disaster, and I think that you need 800 administrators, and that's what the plain deal said. 800, quote, highly paid administrators moved into the Office Max headquarters when it was bought by University Hospitals. There's money out there, and there's money, and when you pay both CEOs at UH and Cleveland Clinic more than $2 million a year, and make it tax exempt. And Floyd Loop retired from the Cleveland Clinic as CEO in 2006 and took home $7.5 million his last year as a nonprofit tax exempt. Get serious.
Yeah, George Rand, I'm an internist, retired, semi-retired internal medicine specialist, and I have to frankly admit that my enthusiasm for working on single payer pretty much dissipated when the ACA came about. And most recently, Deb encouraged me to speak at a one-person play, and I developed this. One of the issues I had was before, when we were talking about single payer, we just had to compare it with what was there before the ACA. But now you have to spend, if you're talking about single payer, you have to explain away the deficiencies of HCA as a part of talking about the benefits of single payer. So I took and created a document where I looked at 3 areas, cost, access, and quality. And I took what it was like in the past, what ACA would do, and how single payer would influence these various areas. And I gave a copy to Deb with the hopes that that would get to PNHP, because I think, it was a simple mechanism for explaining on paper in a relatively abbreviated way what the difference would be between what we had before, what we'll have under ACA, and what we would have under single payer. So I don't know what, if it can be used or what it can be used for, but it seemed like that's got to be part of our efforts to show how single payer would be so much better in terms of those 3 critical areas of access, cost, and quality or outcome. Thanks.
George, first we want to welcome you back. It's been too long. I always look forward to that smile. You have one of the greatest smiles I've ever seen, and stuff. And you do have some wonderful enthusiasm. And George did produce a wonderful document that will become available. We can make it available through the website. And as far as getting it to PNHP, one of the things that we're going to try and do here, and John Ross and I have worked on this, is we need to reach out to our constituencies and our endorsers, and we need to reach out in terms that are specific to them. We send out generic newsletters to everybody, but what we need to do is we need to look at the healthcare community and say, what are their needs? What do they need to know about? And so let's tailor a newsletter for the healthcare community. And then your work can be a part of that. What do the unions need to know about? You know, what are the issues that are affecting them? And so Kurt is going to work on that one so that we can do something on a regular basis with union issues in healthcare. You know, what do the community groups and social justice groups and the faith communities need to know about? And what can we do to help them? What are their issues? And that type of thing. Now, your thing will do a wonderful job of explaining the whole thing to all of them. And so that is in the plans. I do have that, and the plan is to distribute it and to make it available through our web pages. I've got some things that we're going to be doing with the website in the near future.
I didn't develop it as an end.
Right.
I developed it as
It's a living product.
food for thought and for the opportunity to have people look from PNHP, look at it and refine it.
Uh-huh.
I thought it would be a useful tool.
Yeah, and they have one for the ACA versus single payer, but they didn't do before, which you did, and that. So we will get it to them for that standpoint, from that, okay?
Hi, I'm Rachel DeGolia from National UCAN. The speakers were tremendous. Thank you so much. I've learned a great deal today. I'd like to follow up on April's excellent question about how do we make sure that our critiques of what's going on as health reform moves forward because of the ACA, how do we make sure they are strategic? That when people see the horror stories that are coming, that are already coming, the disappointments, that their conclusion is not, what the right-wing ideologues would like us to believe, that government shouldn't be involved in healthcare, but that, the ACA didn't go far enough. What do we do to make sure that people come to those conclusions? How do we help people understand what's really going on? And I'd like to just hear your brief comments about that. One piece we at UCAN think we want to try and address is watchdogging the insurance companies, because the big money players, the insurance companies, the medical device manufacturers, the big hospital corporations, they are seeing their opportunities and taking them right now to game the reform as much as they can. And so part of our challenge is to help people understand what's really happening and what are going to be their conclusions as the problems become more evident.
I think that is central to our movement in the next few years, and as all of you know. And like almost everything else, I think it does depend on the context and your audience. And the town hall, the example of the town hall that I just mentioned, we are trying to reach out to constituents of this assembly member. Most of the people coming into town hall probably have never heard the term single payer, and they are probably, not familiar with the ACA and any details. So for that, we used an extremely simple message, and this is also what I told NPA and Doctors for America in terms of this is how we're conducting it. You can be assured that our campaign is not focused on just talking about the ACA and what we may not be satisfied with. In that context, because the audience is not familiar with what those of you in this room already are, we simply say, we'd like to go beyond the Affordable Care Act and get to universal coverage. That audience does not actually need necessarily more than that. And our state champion, Assemblyman Godfrey, author and sponsor of our bill, he's very aware of those dynamics, and he's aware that some of his colleagues were wondering, kind of worried about signing on. Is this in contradiction to the ACA? We often get that question from legislators, and we explain that, well, this is not in contradiction. We would like to go beyond. The ACA does not do enough. We can do even better, and we want to go toward universal coverage. I don't know of a single defender of the ACA who would say that is universal coverage, right? That's a fact. It is not universal coverage. That is one point that we can all agree on. But in other contexts, obviously, you do need to get into a lot more details, and I certainly don't have a short answer of how to do all that. But I know that I personally and my chapter, we try to stay on that very simple message. We need to do even better. We need to go beyond, and we all want universal, and that's the direction we want to go in. And in situations where people are very familiar but have different political analyses, that's when things are challenging.
Before we break for lunch, and I give this back to Van, I just want to publicly announce that yesterday was Deb's birthday. And since she doesn't eat cake, although I heard she did the other day, this is vegetables in an Atkins bar. So let's sing to her. There you go. Happy
Speech.
Thank you very much. Yes, it was my birthday, and yes, I did eat chocolate cake. And not only did I eat chocolate cake, I ate the potatoes that came with dinner, and I had bread. And you know, there are 3 days out of the year that there are no dietary restrictions: Christmas, Thanksgiving, and your birthday, and I live up to those. So thank you. Earlier at the beginning when we started today's program, you know, I asked, you know, who was here for the first time and issued the invitation to please come back in the future. We want to see a lot of you. Who's been here to since the beginning? Anyone in here that's been here since the first conference? Was that 2003? The first one, somewhere around in there? Stand up, you guys. If you've been here. You know, it's sometimes this work is very frustrating because it seems like that we go in fits and starts and stuff, and we don't get very far sometimes, and sometimes we feel we are losing ground. But this is hard work. There's nothing that's going to get us out of that. This is hard work to do. And when I first got involved, when I came in, you know, I was going to be a liaison to SPAN, in which point I was told I was in charge of Portage County, Ohio, and I said, no, I'm a liaison, and the response was, well, you just got promoted. You know, and from there, then I got onto state council where I was scared of all these people who knew what they were talking about, and I didn't. So I kept my mouth shut for a year, and obviously I should have kept it shut a lot longer than that. But I do look to the people that I listen to, and you know, I keep remembering and telling myself this is a long-term struggle. This is not something, there's not a quick fix to this. It's not going to happen overnight. We have to be prepared for the long term, and we have to understand that we're going to have some successes, some minor successes along the way, and we need to celebrate those, and that we're also going to have some setbacks. But we're here for the long term and for the long haul, and hopefully we can all do that. One of the people that really made this the long haul, and it was Dave that told a story about getting started on an initiative petition. They were going to do this, and you know, he suggested that, and it was Jerry Gordon who said, well, I don't know, we need over 100,000 signatures, and there's just the two of us, and the respondent said, yeah, but there's no time limit, we can do it. And that's the attitude that we're going to celebrate right now, in that spirit that we're going to celebrate with the Bob Smitty Healthcare Justice Award, and I'd like Beth Amariah to please come up. Beth is Bob's wife, and she's going to tell us a little bit about Bob and his spirit.
Coming to this annual meeting was the highlight of his year. And he was here since 2003. And he would be delighted by what has happened. I'm not going to talk about him because he wouldn't want that. Anyone who knows him knows he wouldn't really want that. I could make a long list of how he stood up for his best friend when he was 8 and dropped out of the YMCA because he was Jewish and his best friend couldn't join the YMCA. So that was the end for him with the YMCA. And it went on through civil rights, through welfare rights, through Students for a Democratic Society, through the education fight here in Ohio. But then he came to SPAN, and this was the heart of his life. And his last 15 to 20 years were spent with that. And he would be so delighted by everything that was said by you this morning. And you are such a storyteller, and he was a storyteller. And he just would have rejoiced in hearing and seeing all of you here. His son and I are very appreciative that this honor is given in his name.
Thank you, Beth. Shortly before Bob Smitty's death, SPAN State Council presented him with an award that read, "In grateful recognition of your advocacy and leadership for healthcare justice." And using him as an example for all of us, to honor his life and his memory, we established the annual Bob Smitty Healthcare Justice Award in 2011. It's presented at this conference every year to an outstanding healthcare activist or a group of activists that are selected by the State Council from among those nominated by their peers. This year's award is a joint award. The recipients are 2 supporting groups who have been active for years in the organization. In that time, they've held fundraisers for SPAN, they've marched in parades, tabled at countless events, held informational programs for the community, helped bring a speaker to Ohio from the Vermont Workers Center, lobbied for a seat at the table for SPAN and the Northeast Ohio Medicaid Expansion Coalition, filled buses to go to Washington, D.C., they hold regular birthday parties for Medicare, and anytime there is a request for help or support for an activity in their area, they are ready and they provide it. I'd like April Stoltz and Bob Parker, who are the representatives of these 2 organizations, to come forward, please. Okay. April, as the representative of Cuyahoga West SPAN, I ask you to accept this award. And Bob, as the representative of Cleveland SPAN and your group, I'd like you to accept that award. And members of Cuyahoga West and Cleveland SPAN, would you please stand up? Anyone that are in attendance. Okay.